Good afternoon. Very nice to meet you online. I would like to represent my colleagues and all members of Alzheimer's Disease Chinese ADC to express our gratitude to all ADI members and those who have supported us in fighting against the novel coronavirus infection during the past 2 months. I would also like to thank Alzheimer's Disease International ADI for inviting me to give this talk. It's my great honor to share our experiences for addressing dementia care during the COVID-19 outbreak in China. There have been more than 153,000 cases diagnosed and confirmed with infection worldwide. All the adults were vulnerable during this outbreak. Among them, persons with dementia are at high risk of being infected and affected by the disease. Now, China has contained the outbreak to some extent. How did we address the challenges of dementia in this difficult time? I would be happy to share some of our perspectives and the local practice. Hope it could help us to maintain the quality of life of persons with dementia in the battle with the global emergency. Today, my talk consists of 3 parts. Concept of continuum of dementia care, the impact of COVID-19 outbreak on persons with dementia and their carers, and how we could help them with mental health and psychosocial support. First, I would like to address the importance of providing continuous dementia care. According to the recent estimate of ADI, about 50 million people lived with dementia in 2019. Every 3 seconds, there was a new case. Now, dementia has been listed as one of the global public health priorities by World Health Organization. In response to the grand challenges of dementia, a whole of society approach has been proposed in China. It has been implemented in some cities. Within the whole of society framework, the core of the goal is to maintain function of persons with dementia. To achieve this goal, family should be supported. The function of communities should be maximized. In the macro level, different stakeholders in the society should collaborate. Dementia care is a long journey challenged with a significant economic burden, care distress, and increasing service demands. In China, dementia care primarily depends on the healthcare providers, especially in the mild and moderate stage. Strategically, the continuum of dementia care has 4 major elements: risk assessment, timely diagnosis, sufficient post-diagnostic support, and adequate care support. The WHO Regional Office for the West Pacific region, WIPRO, developed a dementia toolkit for community workers in low and middle income countries. Improving access to care is the key to minimize the gap between diagnosis and treatment of dementia. In addition, as most old adults live in the community, making use of community resources might improve the pathway to care for dementia. Primary care physicians and non-specialists play a more significant role in diagnosing and managing dementia, given the insufficient number of specialists in hospitals. Furthermore, outreach in the community and regular home visits are considered essential for timely identification of dementia. Therefore, we are implementing a specialist community collaborative management protocol. In medical practice, memory clinic is the optimal setting for comprehensive assessment and evaluation, making a diagnosis, and creating the treatment plan. and providing follow-up in dementia care. Also, specialists in memory clinics could supervise the post-diagnostic support and follow-up visits in the community. Following the clinical management algorithm, physicians cared not only for brain health status, but also for comorbidity and safety issues. Now, I would like to discuss what did the COVID-19 outbreak impact on persons with dementia and their carers. Dementia is characterized by cognitive decline, which is always accompanied by behavioral and psychological problems and functional limitation in daily living. There had no evidence that the coronavirus would cause rapid cognitive deterioration, as long as the person maintained routine medical care and continuous care with drug and medication. The cognitive status would not change substantially. However, due to several factors, there might have been psychological and behavioral responses to the epidemic among those living with dementia. After the outbreak, 5 organizations, including Chinese Society of Geriatric Psychiatry and Alzheimer's Disease Chinese ADC, collaboratively developed the expert recommendations on mental health and psychosocial support, MHPSS, for persons with dementia and their carers during the COVID-19 outbreak. Now, the full text of this paper in Chinese has been published by Chinese Journal of Psychiatry and now has been available online. We also developed the key messages of the expert recommendations. The key messages have been translated into English and will be disseminated through ADI. My following slides were extracted from the expert recommendations. During the outbreak, persons with dementia had different experiences depending on where they were placed. People who were suspected or confirmed with the infection were mostly placed in the intensive unit ICU of a hospital. They were exposed to a new environment with isolation surroundings. They may have experienced somatic discomfort and even hypoxia. Most of persons with dementia continued staying at home. They had limited access to accurate information about the epidemic, had difficulties in remembering and understanding the situation. The outdoor social activities were prohibited. Thus, their home life was not well scheduled. Or, due to travel restriction or self-quarantine measures, the care workers could not return to work. There had to be a replacement of care. Those who lived alone or had no carers might have made their daily living more disorganized due to great demand for cognitive processing in this difficult time. For those living in assisted living facilities or nursing homes, the extended lockdown rules might have caused great problems. Visits from family members were banned. Group activities were prohibited. Hand-to-hand touch were decreased. During the first 2 weeks of the outbreak control, due to transportation restriction in cities, they had no access to routine clinic, and the essential medication might have been interrupted. Therefore, persons with dementia had different psychological and behavioral response to these different situations. In the ICU, all medical staff wore preventive suits and masks. It was difficult to identify their faces. When exposed to such isolation surroundings, persons with dementia had a strong feeling of insecurity. They presented anxiety, had sleep problems, became agitated, and even were hostile and aggressive against medical staff. Since the infection caused strong somatic discomfort, such as fever, coughing, fatigue, difficulty in breathing, the persons with dementia might have presented with challenging behaviors, such as agitation, irritability. Most cases of infection had severe hypoxia, which caused the delirium quite often. In such cases, the persons with dementia were characterized by the acute change of consciousness and the sleep-wake cycle disturbance. Some may have presented with hallucination and emotional disturbances. For persons living at home, anxiety and irritability were quite common. When they had low awareness or limited access to accurate information and facts, these persons presented excessive stress and tension. Some had sleep problems. Changes in home care arrangements was one of the major concerns, as the persons with dementia needed a break-in period of replacement of cares. He or she might have presented with more challenging behaviors, such as mood problems, irritability, and wandering. Some developed delusion against the replacement of care. Also, the care anxiety caused the person they cared for with greater emotional disturbance. Due to the enforced social distancing or staying at home, they felt bored and lonely and presented with anxiety, irritability, and agitation. When their daily life were not scheduled, they had more naps during the day and had sleep problems at night. They spent more time wandering at home. Due to the decline in memory and comprehension, they had difficulties in remembering safeguarding procedures, such as wearing masks. All had difficulties in understanding the public health situation and information issued to them. Sometimes they showed uncooperative to care, and sometimes they had conflict with carers. During the isolation period, they became more disorganized, as the daily life had a great demand for cognitive processing. For example, they had to remember wearing masks before going out, had more frequent hand washing or sanitization than before. Family members had more closer observation about the changes of cognitive problems and would be more concerned. As nursing homes and assisted living facilities implemented strict virus management regulation, old residents lost face-to-face contact with family members, and group activities were prohibited. As a consequence, they become more socially isolated, presenting apathy and withdrawal. They also became restless, not knowing what happened and what they could do. The outbreak also caused great concern for carers. Family members and carers may have an additional response to the stress caused by the emergency. In Chinese culture, family members were responsible for making decisions for the senior citizens they cared for. During the outbreak of COVID-19, family members, such as a spouse or children, might have felt additional stress, as they were also worried about the possibility of being infected and its consequences. The paid carers were confused about the situation, worrying about their own families living far away, feeling panic sometimes. They became more irritable. Persons with dementia presenting challenging behaviors contributed to greater caregiving burden. In nursing homes, There were fewer staff than usual during the COVID-19 outbreak, as some carers who had left for the Chinese New Year vacation were placed in quarantine after traveling before they could return to work. The workload of the remaining staff increased dramatically, and many carers presented with signs of exhaustion and burnout. They felt fatigued, lonely, and helpless. Now let's discuss how we could help those living with dementia and their carers. In the expert recommendations, we developed an interdisciplinary resolution for mental health and psychosocial support. It called up the multidisciplinary collaboration from mental health professionals, social workers, nursing home administrators, and volunteers. The package included psychosocial first aid, aiming to support those who were exposed to the outbreak suddenly, self-help counseling and support, aiming for those with mild dementia and the carers, behavior management, aiming to support those with emergent or aggravating challenging behaviors, clinical management for delirium, and a guide for newly identified cognitive impairment. For those who were exposed to the outbreak suddenly, for example, being told of positive testing results, running out of preventive and sanitizing supplies, psychological first aid should be provided by the staff on site. Most importantly, the urgent needs and concerns of the person should be assessed. Then the staff tried best to meet the basic needs of the person, comforted him or her, and helped him or her to resume the sense of security. In such a situation, listening to the person was more helpful than persuading him or her. In case of the person learning the news of being confirmed with the infection, it was critical to help the person be placed appropriately as soon as possible. Self-help psychological counseling and support was applied to those with MCI, mild dementia, and carers for all persons with dementia. Everyone should be accepting to the physical and psychological changes of the person with dementia and themselves. Several approaches were proposed and were accepted by most of the affected people. For example, they were encouraged to obtain information through authoritative channels to avoid media noise. If necessary, persons with dementia could use memory aids, like notebook, to write down the key messages. Online cartoons were available for supporting the people to understand the virus and the self-protection measures. The importance of strengthening self-protection were conveyed through online public lectures, doctor's advice, and the WeChat broadcasting of ADC and local memory clinics. We also encourage them to seek support from family members and friends through different media platforms. Relaxation and mindfulness exercise were presented on the media platform. People could choose to use with the instruction online. Also, during the outbreak, there were many free online courses like music, art, and cooking. We encouraged people to attend online courses, to try learning a new thing, and enrich his or her life arrangements. Concerning the challenging behaviors, we encourage the carers and the professional service providers to choose non-pharmacological intervention as the first-line option. The DICE procedure proposed by Dr. Kales, including describing the behavior, investigating the potential factors, creating management plan, and evaluating the outcome, were very practical. If the challenging behaviors or psychological symptoms do not improve, we recommended the person should be referred to psychiatric services or liaison consultation if they were hospitalized. To effectively investigate potential factors of the behavior, we proposed exploring the factors related to the person with dementia, his or her carers, and the environment he or she was placed. More specifically, if the behavior was caused by the environment change, we recommended considering setting up special areas for persons with dementia in the ICU of a hospital, where light and sound were appropriately adjusted, providing a soothing environment. Staff were trained to attend the emotional experience of the person and tried to communicate in a simple and clear way. When the carer was replaced, the new carer was supported to develop a positive attitude and learn more caregiving skills, especially the validation technique. To reduce the restlessness and wandering due to unscheduled home life, the carers could design appropriate activities. It was very important that the carers should accompany and encourage the person to participate. For those who were unable to comply with the self-protection measures, the carers were suggested understanding the reasons for the behavior and trying to provide practical help. If the person had to take on high demanding work, the carers could break down the work and give step-by-step instructions. Also, we could use pictures to remind the person of those protective measures. When appropriate, a brief compliment or encouragement was able to cultivate a sense of accomplishment. If the person had physical discomfort, the carer could try to alleviate the physical condition, and if necessary, with symptomatic medications under the physician's instruction. For the person with delirium, it was critically important to follow the algorithm for managing delirium in ICU, including treating infection, ensuring adequate nutrition, vitamins, and water supply, reducing unnecessary clinical procedures. The care team should consider providing non-pharmacological interventions to the people living with dementia, such as offering accurate orientation information and providing moderate light and sound stimulation. It was important that delirium was not misdiagnosed as aggravating challenging behaviors. With such cautions, the person with delirium adding on dementia would be treated timely. For those who were identified with cognitive impairment during the isolation period, we highlighted that nowadays, prevention and control of COVID-19 was the priority. After the situation was resolved, they could consider seeking assessment and a diagnosis from memory clinic in local hospitals. Currently, in order to lessen the chance of infection, comprehensive neurocognitive assessment that needed at least 1 hour of close contact in the testing room had to be suspended. The assessment would resume with further notice. In addition, carer support group now started gathering through virtual meeting room platform. We tried every effort to support persons with dementia and their carers in a safe way. To summarize, I would like to share several key messages that would support persons with dementia and their carers worldwide. First, provide continuous dementia care in a safe way. probably through virtual platforms, and try every effort to keep essential drug medications uninterrupted. Second, during the COVID-19 outbreak, it would be very efficient to organize a multidisciplinary team for dementia care. Also, if new dementia-related problems emerged or aggravated, please support the family to seek timely evaluation, diagnosis, and treatment. Personalized non-pharmacological intervention remained as the first-line option for persons with dementia during the epidemic. And last, encourage persons with mild dementia and carers to use self-help psychological support. This was useful to reduce stress. In addition to the expert recommendations, we also published a book on psychological support in lay language, specifically for old adults, family members, professional carers, and social workers. The printed and audible version were both free online. Recently, there's still an ongoing survey to understand mental health status of old adults and carers during the outbreak in China. We hope we could share more data with you in the future. Again, I sincerely thank ADI for organizing this webinar. I hope our experience in China could be adapted and used in your local context, and look forward to a sustaining environment for persons with dementia and carers worldwide. Thank you very much.